you guys heard from my co-resident, I think last week, about the menstrual or female cycle disorders. So I will be talking with you guys today about contraception and infertility, and then the both of us will be back tomorrow to talk about male health. So before we jump straight into content, I wanted to just give you guys a little background about who I am. Like I said, PGY2 in ambulatory care. I did my PGY1 also at Harris Health System, which is a general residency program. And I graduated pharmacy school from Texas A&M down in Kingsville. I grew up in a small town southwest of Houston. It's about an hour and a half away. It's called Bay City. It's not Baytown on the east side. It's Bay City on the southwest side. It's very, very small. My graduating class was like 120 kids. We had one high school. Very, very small. So I thoroughly enjoyed living in Houston, getting to experience all the foods, cultures, all the fun things to do, kind of in your very walking distance type of environment. So that's a little bit about me. If you guys have any questions about the content throughout, please feel free to raise your hand and we can stop and ask throughout. I'll also leave time at the end, and then my contact information is on here. I also would love to talk with anyone about residency or kind of what happens after you guys get through pharmacy school. I know you guys are probably looking forward to being done with your P2 year onto your last didactic year coming up. I'll go ahead and get started. Like I said, if you guys have any questions along the way, just let me know. Alright, so we're going to start with contraception. When it comes to exam material, because I was just in you guys' shoes, I always liked little tips and tricks, little hints to exam material. Most of my questions come from this portion. The infertility portion at the very end is small and will be more content-based. This is where kind of those case-based questions will come from. Because it is kind of something that comes up more frequently no matter what practice of pharmacy you end up going into. So, for our objectives, differentiating the difference between the hormones that are used for contraceptives, recognizing the different regimens and adverse effects that are associated with those regimens, counseling patients, and then recommending additional non-hormonal-based contraceptives when needed. So we'll kind of start off with a little just kind of background on the pathogens. I think someone has covered this a little bit before me, but in order to kind of understand how the medications work, knowing this pathway is very important. And so the hypothalamus is where it all begins. This is where the gonadotropin-releasing hormone is released from. It acts on the anterior pituitary, which releases FSH and LH, so our follicle-stimulating hormone and luteinizing hormone. These two hormones are very important in the contraception cycle or just the general female menstrual cycle. And these will then further go to act on the female anatomy to release the sex hormones such as estrogen and progesterone, which will be the main parts of our contraceptive options. This cycle, much like most of the endocrine system, is regulated by a negative feedback pathway, and so that is important along the way. So the menstrual cycle can be broken down into 4 different phases. The normal cycle ranges anywhere from 23 to 35 days, depending on the woman. Average is about 28 days or 4 weeks. Changes in the hormone levels cause the different phases to occur. And so we'll kind of go through this large graph and go to be able to recognize the trends and which causes what part of the phase is. So the first phase is menses, and menses is the shedding of the lining of the uterus. Menses marks the very first day of the cycle and commonly referred to as a period for the women. So menses is going to be the very beginning of the cycle, and this also marks the beginning of the follicular phase. So when it comes to the follicular phase, like I mentioned, day 1 is menses, but as we kind of look at the graph, starting at the beginning with our FSH and LH portion at the top, that's the higher levels of FSH is what stimulates follicular maturation, and so basically meaning the ovaries have a immature egg that is maturing and preparing to get fertilized by a sperm if the world does say so and allows that to happen. The FSH spur, like I said, it promotes development of that immature egg. And at the end of this cycle, you can see at the kind of the third column that the estrogen is spiking, and this is what will kind of be the marker at the end of this phase. So the beginning, FSH is high, and the end, estrogen is high, all caused along the way. For ovulation, this is right in the middle of the cycle, around day 14. This is where you can see peak levels of both your FSH and your LH. So this surge is what causes ovulation. Ovulation is the actual release of the egg from the ovary. The LH surge is the actual trigger, and ovulation typically occurs about 24 to 36 hours later. The ovum is then swept through the remaining part of the female anatomy to the fallopian tubes where fertilization could occur if there were two sperm in the area. Ovulation is the beginning of the next phase, which is the luteal phase. So as we continue along the graph, the luteal phase, this is where the follicle transforms into the corpus luteum, and this specific part of the cycle secretes its own progesterone. And I have this kind of progesterone emphasis on the gest because progesterone is what is a main player in supporting pregnancy. So if the immature egg is fertilized, it becomes corpus luteum, and progesterone will start taking over, which prepares the uterus for implementation and also for the 10-month gestation period if it were to be fertilized. This also decreases the uterine contractility in order to support a pregnancy for the full term. It also prevents a second ovulation and fertilization, so you don't end up with twins, triplets, onward from that point. So if there is no fertilization, at this point, the uterus will start all over, shed all of the work that it just did, and start back at day 1. It's kind of a lot of information. Any questions on that part so far? So, as I mentioned at the very beginning, the FSH, LH, estrogen, progesterone are the key players into understanding this whole cycle. Estrogen and progesterone are going to be the two main components of our hormonal therapies. And so for our estrogens, typically there are 3 that are available: ethinyl estradiol, or typically you can see it's abbreviated as EE. This is the most common form of estrogen in our birth controls. This is the pharmacologically active form of estradiol as well, or estrogen as well. Doses range anywhere from 10 to 15 micrograms, and it is important to know that low dose estrogen therapy is considered 35 micrograms less or less in a combined oral contraceptive. Estradiol, Valerian, and Mestranol are also available, they're just not as common. When it comes to our progesterones, there are 3 different types of progesterone. Analogs are pregnenes, which are very similarly structured to progesterone. This is medroxyprogesterone, which is the Depo-Provera shot, if anyone is familiar with that. The S strains are similar, but not exactly the same as progesterone in the medicinal chemistry structure. But these progestins do have androgenic activity. And androgenic activity can cause some side effects that most women may not necessarily want, such as extra hair growth, acne, oily skin, weight gain, things of those nature. Our gonads also are similarly structured, but these do have less androgenic activity due to their chemical structure. And these you will see used quite frequently because of that positive side effect. And then also strong lactone derivatives or anti-neurocorticoid or also anti-androgenic aldosterone antagonists can be used as well, but I won't be going too far into that today, more so into the hormones themselves. So to kind of quickly summarize the key roles of estrogens, progestins in relation to the FSH and LH surges in the cycle. I have this nice graph here for you guys. So estrogen, the estrogen component of our birth controls, is most active in inhibiting the FSH release. At higher doses, it also can inhibit the LH surge as well, and therefore can suppress ovulation in that form. Progestin is mainly the LH surge for inhibition of the ovulation. Estrogens also potentiate anti-ovulatory effects of those progestins, kind of like I said, that LH surge at higher doses. But their main function is really stabilizing the endometrial lining to limit breakthrough bleeding and also kind of providing that cycle control that can be sought after for people on birth control. Progestins, like I said, LH surge is their main focus. They also thicken cervical mucus, which prevents sperm penetration, slows motility throughout the female anatomy, and also induces kind of an endometrial atrophy to therefore not support a pregnancy. Before we kind of go into types, any questions on the hormones, kind of pathophys behind the different types? Okay, cool. So when it comes to the different types of hormonal contraceptives, there are, like I said, typically estrogen progesterone combinations. There's pills, there's patches, there's vaginal rings. There are the common abbreviations you may see: combined hormonal contraceptives, so it's anything that has both of the hormones in it, and combined oral contraceptives, of course, are the pill versions. There also are progestin-only options in a pill form, injectable implants, and IUDs or intrauterine devices, and we'll go over that briefly. So this is something that I've actually pulled up multiple times for patients when they ask about birth control methods. And this kind of just shows the effectiveness of the different types of birth controls or contraceptive methods available. Women, if not using any method at all, have an 85% chance of getting pregnant. And so therefore, if pregnancy is not desired, some form or fashion or combination of them all needs to be used in order to prevent that. So you can see, as you go from the bottom to the top, the different effectiveness and how this can be used to help make the decision of what would be best for a specific patient. I'm not going to ask you specific percentages, but generally knowing, that the kind of over-the-counter options are a little less effective when used alone. And then as you kind of work your way into the prescription-based formulations, you can see that the patch and ring are a little bit, are about the same as the pill, but less effective than the injectable. And then when you go into the more invasive type formulations, such as the implant, the IUDs, or actual sterilization via surgery, the change in percent risk of pregnancy with those is different. When it comes to something that we always have to talk about is when discussing contraceptive options, it is important to make sure that patients are aware that these not all of the options protect against STDs, and so still practicing safe sex is important. Another important learning point is, I've had people ask me this in the pharmacy as well, is kind of, you can use combinations of these things, but certain things should not be used in combination, such as, using a male and a female condom. Both of those together could create friction and then kind of negate the entire purpose. And so making sure to be able to counsel on some of these points, again, not for the test, but we'll kind of go through them as we go through each of these different options. So most commonly that you'll run into specifically as a pharmacist is going to be the oral contraceptive regimens. Most of them, as I mentioned previously, do contain ethinyl estradiol and a type of progestin. Some common abbreviations you may see low, like I mentioned previously, is any estrogen component less than or equal to 35 micrograms. and this would provide less estrogen side effects, and we'll go over kind of the specifics when relating to those hormones in a moment. And then Fe, or iron, the chemical on the table, periodic table, Fe for iron is included because iron supplementation is important when on these medications. Most commonly, the birth control packs come in a 28-day supply, as the average menstrual cycle is about 28 days, with 3 of the weeks being active, 1 week as placebo pills. There are different formulations of the birth control packs where you can have shortened cycles, extended cycles, continuous cycles. So shortened cycles would basically mean there's more active pills, so instead of 21 active pills those first 3 weeks, maybe there's 24 or 26, leading to a shorter period for only 2 to 4 days instead of the 7 days. So once the hormones are removed is when the period would occur. Extended cycle is taking pills, active pills continuously for maybe 2 months at a time, 3 months at a time before breaking the hormone replacement time or hormone time to allow for a period. And so this could be sought after for patients who have very extreme period symptoms and therefore would like to avoid having a period each month. And then continuous cycle, there are formulations available now that don't require a stop in time at all. As you kind of extend that cycle, there is a risk of breakthrough bleeding every once in a while, but it is possible to go without a period for years at a time. So, when looking at our oral contraceptive options, there are different types of formulations when it comes to the proportion or the amount of hormone in each pill. And so monophasic, meaning that the hormone concentrations of your estradiol and your progestin stay the same throughout the entire pill pack. Biphasic means that it changes at least once. Triphasic means it changes twice. Biphasic, typically the progestin is what changes about halfway through to kind of mimic the normal female cycle, but the estrogen will remain the same. I'm sure there are some exceptions to the rule, but typically that is how that happens. And then for triphasic, depending on the brand, estrogen may change as well, but most of the time it is that progestin component that is being adjusted. Please do not memorize brand names, generic names of any birth controls because they change every 5 seconds. Sometimes there's one available and sometimes they're not, so don't memorize them. I will not ask you that. And some of the case questions later, I'll kind of show you how it would look in an exam so that you can be used to that. So you can kind of see. So this is just to kind of show how to identify monophasic, biphasic, triphasic. Again, just examples, please don't memorize which one's which, but I tried to pick, so these are all Nikon, which is a norepinephrine and an ethinyl estradiol tablet. So you can see in our monophasic example, Nikon, the 135 for 28 days, all of the active pills in the 3 weeks are the same color. So that means the concentration is not changing until the placebo pills in week 4. In the biphasic example, Nikon 10/11 for 28 days. It's kind of hard to tell. Yeah, it's somewhere around that middle part. There's a lighter yellow, a darker yellow. So there's your change in the middle, and then it goes to a placebo week at the end. And then triphasic, I think you can see it here, kind of here. So you have the 3 different phases, usually about a week of one concentration, another week of another, a week at the end, and then the placebo pills at the very end. And so this is just kind of to familiarize you guys with the options that you may see out in the real world when you are able to practice. And really the difference here is as you introduce more phases, referring back to that first graph, the different hormone concentrations, it starts to mimic what a normal body would kind of look like throughout the entire cycle. So when we are, to talk about our combined oral contraceptives, progestin-only pills are also an option. These are commonly referred to as the mini pill. I'm not sure if anyone has ever heard that before. I feel like I haven't heard it frequently, but heard it at some point in my life. And these progestin-only pills can also be purchased pops. These contain only a progestin, most commonly norepinephrine. This option of birth control is less effective than our combined oral contraceptives, but they do provide some other benefits and are preferred in some patient populations. So for women unable to take estrogen-containing contraceptives, these options are less thromboembolic. They also can eventually induce basically no period, so it's a positive as well. But the kind of downside of this in relation to them being a little bit less effective is that they must be taken at the same time every day. Or, we counsel patients all the time, take your pills at the same time each day for the best efficacy, but here, I believe, I should look this up beforehand, but it's like 30 to 45 minutes. If you miss it by that chance, it's completely ineffective. These are also commonly used in patients that are breastfeeding after having a baby because of the risk for VTE or thromboembolic risk that is associated with pregnancy alone. But again, most importantly, these have to be taken at the same time every day, very consistently, in order to have the most effective, contraceptive effects. So, kind of getting into where you would use the different, you can use combined estrogen and progesterone or just progesterone only. We kind of have to look at the positives, risks and benefits of the different options kind of in relation to those hormones. And so non-contraceptive benefits that come from our combined oral contraceptives, decreasing risk of endometrial ovarian cancers. This is somewhat, when I was looking into the literature, somewhat kind of argued about, but there is supporting data that shows that there is a decreased risk, more supporting data than there is against it. Regulating menstruation, we spoke about previously, decreasing the risk of anemia, kind of on the basis of you're bleeding less and more controlled, so therefore women would have less risk of anemia overall. Fetal neural tube defects comes from having that iron, folic acid supplements in them, some of them do, as well as kind of relieving those symptoms of the painful periods, as well as endometriosis symptoms. Improving acne are all potential other benefits that can come alongside contraception alone. And sometimes you can see these medications or the birth control packs used for other indications such as acne control or for painful periods or endometriosis alone. The risks of the combined oral contraceptives, as we mentioned previously, sexually transmitted infections. These do not protect against those. So if a patient is having multiple partners, unprotected sex, they would still be at risk for sexually transmitted infections, and therefore a barrier method would be recommended in order to protect them against any sexual transmitted diseases. Cardiovascular events and hypertension are higher risk for patients specifically from the estrogen component. Hypertension at high doses of estrogen, typically more than 50 micrograms, there is a risk for uncontrolled hypertension, which could then increase the risk of myocardial infarctions and strokes. And so this is something that's important to take into consideration in patients who already have hypertension or have had a prior history of any type of heart attack or stroke. It also is required by the CDC for the primary care provider or whoever is prescribing birth control to monitor a patient's blood pressure to ensure the best safety when it comes to these cardiovascular risks. Venous thromboembolism is something that I think most people have heard of beforehand, that birth control can increase the risk of having clots. Again, from the estrogen component, most of these come from. There's about a 2 to 3-fold increased risk in patients that kind of have other risk factors such as obesity, smoking, hypertension, diabetes, recent immobilization, such as like for long-term surgery, or even a lot of times they'll mention the risk of sitting on a plane for 8 hours to go across the seas. So being aware that there is these risks that come with the oral contraceptives, it's important to weigh those before making recommendations for which is to be initiated in a patient. Also, lower risk, less supporting data is the gallbladder disease and hepatic tumors, but proceeding with caution with patients that may have those, as they're in their past medical history probably. So when it comes to contraindications, again, I won't ask these, verbatim, but kind of understanding why I think is most important, and kind of going over the absolute I think will be easier, and then you can relate them back to the relative contraindications. And so for pregnancy and 21 to 42 days postpartum, the risk of venous thromboembolism or clots in pregnancy is much greater than that of a birth control, combined oral birth control. And so that is important to know, but there is a period, of course you don't want to take it during pregnancy, but after pregnancy that risk continues, and so not starting any additional estrogen in that time postpartum is important to ensure that we do not increase the risk of having a clot for these patients. If they have history of clots previously, strokes, any type of cardiovascular disease such as coronary artery disease, ischemic heart disease, peripheral vascular disease, all of these can put them at higher risk for strokes or clots. We don't want to start those in these patients. Breast cancer, because breast cancer comes from estrogens, and so providing additional estrogen could then promote cancerous growth, which is of course not something we desire. Undiagnosed abnormal uterine bleeding or vaginal bleeding is also something that can be exacerbated by additional estrogen. Heavy smoking increases the risk of hypertension, clots, cardiovascular disease. So you can kind of see the trend here, where there's a lot of contraindications and considerations that need to be made for people with heart disease specifically. Again, hepatic tumor, liver disease, as we talked about previously. But something to also note is migraine headaches. And so the reason this is on here, which I feel like as a student was always kind of confusing to me. So migraine headaches specifically with focal neurologic symptoms, or can also be referred to as an aura, or aura, A-U-R-A. So patients will have kind of like a prodromal symptom, typically kind of similar almost to stroke symptoms. And so we don't want to use these estrogen-containing birth controls in patients with this disease state specifically, because you run the risk of confusing their migraine-related kind of aura, focal neurological symptoms with signs and symptoms of a stroke. And so for these patients, estrogen-containing birth controls are not recommended, actually contraindicated. On the relative side, it is kind of helpful to read into, so smoking, 15 cigarettes a day is kind of the cutoff, and then for age cutoffs, 35 is where you start questioning if the cardiovascular risk versus benefits when it comes to using estrogen-containing birth controls is important. And then for the hypertension, the WHO, or World Health Organization, has defined blood pressure unacceptable hypertension, basically of any systolic greater than 160 or diastolic greater than 90. Otherwise, I think these make sense off of what we talked about so far. I've had this slide up for a little bit. Does anyone have any questions on anything that's on here so far? All right. So kind of getting into our special drug formulations, as we've kind of hit on a lot of the oral options, there's also the patch version, and we'll kind of get into the vaginal ring as well. So the patch that's available, brand name is Xulane, and it is an ethinyl estradiol and a norelgestromin. This important counseling points for this when you see patients in the outside at a pharmacy is the application sites. And so you can see it can be placed on the abdomen, the bottom, upper torso, or upper arm. This is helpful for patients because it's replaced weekly for 3 weeks instead of having to remember to take a pill every single day. The 4th week is patch-free, similar to the pill types where it's your placebo week where you will have the period. After taking out the patches, it's important to kind of counsel them to fold it together so that the estrogen is not leaking out once it is disposed to provide safety for children around the house, pets around the house, and then wherever all of our trash ends up eventually. Another kind of special formulation is the vaginal ring, so NuvaRing, also ethinyl estradiol with the etonogestrel. This, in comparison to the patch, is left in or inserted on day 1 of the cycle and left in for 3 weeks, but still has a 4-week ring-free period. So again, kind of increasing the, decreasing the need for medication adherence, where it's only having to be changed, once, inserted once, taken out once in a cycle, where the patch is 3 times in a cycle, pills are every single day. Kind of a unique thing of the NuvaRing is as long as you can take the NuvaRing out, because a lot of concerns that some patients have brought up is, can you feel this NuvaRing, in the intimate moments? And so, typically, you can remove the NuvaRing for up to 3 hours, and then reinsert as long as it hasn't been greater than 3 hours, if that is a concern for, a woman or intimate personnel. So also if it happens to fall out or you notice it's been gone, as long as it's been less than those 3 hours, you can rinse and reinsert as soon as noticed. So that was kind of unique. This is an FYI slide, no questions on this, but just wanted to let you know that there are other options. We're not going to go too far into them. The injectable Depo-Provera I have at the top, which we kind of talked about, is the medroxyprogesterone, most similarly structured to just progesterone alone. The intrauterine devices, and then also implantable, so this is the Nexplanon, which I know every single person has at least seen one commercial for Nexplanon. This is just kind of a reference for if you need it in the future, the duration, and which ingredient is in which. So when it comes to actually deciding what therapies to use, the goals of therapy typically are to prevent pregnancy, but again, as we mentioned, there's other potential uses for these medications, such as cycle regulation, reducing those pre-menstrual symptoms, acne treatment, et cetera, et cetera. But also, we want to make sure to provide the most cost-effective options and minimize any adverse effects. When it comes to kind of your patient workup, making sure to look at the medical history to kind of identify any of those contraindications or kind of needs for special considerations in their past medical history. Like I said, blood pressure is required. And then looking at baseline weight, BMI, as well as a required pelvic exam and cervical inspection to make sure there's no abnormalities with the anatomy. Before starting birth control, of course, it is important to rule out pregnancy. And so these are the criteria for which you can consider someone, out of the pregnancy window. So no signs and symptoms of pregnancy, obviously, plus one of the following. So it has been less than 7 days since the start of normal menstruation or start of the period, then it's okay, safe to say, we can go ahead and start. No sexual intercourse since the last menstrual period. Correctly and consistently using reliable method of contraception, which is up to interpretation, and I don't know if I would trust any patients by their, word only. A spontaneous or induced abortion within this past 7 days, 4 weeks postpartum, or breastfeeding for a majority of the feeds with no period and less than 6 months postpartum. So all of these are considered no risk for pregnancy, and so therefore safe to start using contraceptives, hormone contraceptives. Otherwise, would need a pregnancy test to roll that out and then continue. So this, again, is just kind of a helpful slide, the U.S. medical eligibility criteria chart. So this is provided on the CDC website. It is used to help kind of make the decision. It will not be on the test, but it is pretty cool to have available if this were to come up in your practice months out in the real world. You know, it takes into consideration all of the different things we've talked about so far: patient's age, their medical history, their medication list, and based off of all those conditions, this graph will provide basically options that are recommended for use or not recommended for use based on that person specifically. It is a 2-page document. I've provided the link in your guys' slides if you'd like to take a look at it. It's helpful if you were to use it in your practice. Also, if you want to gander out of, you know, looking, studying for the exam, it would give you real life kind of examples of, you know, a patient who isn't just, hi, I'd like my birth control. Our patients come in and, you know, they have 15 different disease states, probably 1 eye and 7 kidneys, and you gotta figure it out. So this is kind of helpful practice for the real life. Alright, so when it comes to starting birth control pills, there are different methods that you can take in order to start. So a first day start, if the patient is in their first 5 days of their cycle, so day 1 of their period up to day 5 of their period, no additional hormonal contraceptive or non-hormonal contraceptive barrier method type contraception is required. If the patient is another type is a quick start, and that's basically seeing them in a visit, they want to start right away, that's fine. Your cycle will sync up, you know, after a cycle or 2, but it does require 7 days of a non-hormonal contraceptive to prevent pregnancy in that initial first week. Sunday starts are common because this helps to avoid weekend menses, and so basically starting the first Sunday after a period, if it happens to be on the first day of if the first day of their period is on a Sunday, then no hormone contraception required. But if it's in the middle, if it starts before then, 7 days is also required. So basically, if you're starting anywhere after your first 5 days of the cycle, first 5 days of period, you require 7 days of non-hormonal contraception. The only time you can just start and be safe is in the first 5 days. Later missed doses comes up very frequently, and so this is, you know, a very big concern because this is what can cause contraception to fail. It is important to probably check the specific prescribing information for each individual agent, but generally you can use the 48-hour approach to decide. And so basically, if a patient comes to you and it's been, so 48 hours means they realize they have missed yesterday's dose or I guess 2 doses, excuse me. So today they're realizing they haven't taken the past 2 doses. If there's only 2 pills that you are behind, then they can basically just double up and get back on track. So 48 hours ends up being 2 missed pills, but as long as they're realized, start as soon as possible. If it's been more than 2 pills or greater than 48 hours, then we go back to the 7 days of non-hormonal contraception in order to ensure that pregnancy is avoided. And then this kind of 3rd week caveat basically means that because there's already been 3 pills missed, in order to catch up, it will end up taking over the placebo week. And so the patient won't create their own placebo week, just continue as it works out by doubling up until you're back on track. Any questions on that? When it comes to drug-drug interactions, it is important. I know that this comes up quite frequently also when I was counseling patients in an outpatient setting, is a lot of the times they don't know about the anticonvulsants or anything like that, but antibiotics comes up a lot. And rifampin is the kind of the origin of where this interaction comes from. Because of its CYP effects, this decreases the estrogen and progesterone, and therefore does have this drug-drug interaction that would increase the risk of getting pregnant, decrease the effectiveness of birth control. antibiotics, may alter the intestinal flora, which, in the long term will reduce the amount of circulating hormones. And so therefore there is some drop, or theorized drop in estrogen levels, but there is no clinically significant studies showing anything other than rifampin. But for those broad spectrum antibiotics such as your penicillins, your tetracyclines, rifampins, recommending a barrier method or a non-hormonal contraceptive is okay to do as well. But it is important to know the other examples, potential for the test, are anticonvulsants being CYP3A4 inducers. And so if you are causing the medication to be metabolized faster, so inducing their metabolism, then therefore it is not, there's not as much around in the body to provide the efficacy needed, and that is where you can see that the anticonvulsants such as carbamazepine or big drug-drug interaction causing agents cause the hormone levels to be less and increase the risk of pregnancy. So if patients are on these medications for extended periods of time, it is kind of a conversation to have to consider changing to a different type of birth control that would not interact. And so typically the cutoff for that is any time greater than 2 months. Consider changing to either one of the injectables or an intrauterine device would not interact with these drugs. So for those hormone-related adverse effects, we've hit on some of these, but this is probably a pretty important slide because many of the side effects that can come from the estrogen component or the progesterone component can be minimized or avoided altogether by just adjusting the different concentrations of the two hormones. And so I have set up in kind of estrogen on top, progesterone on bottom, and the differences between an excessive amount or not enough. And so you can take a look at a patient's birth control and adjust accordingly if they're having any of these symptoms. So estrogen, which makes sense if you look at these, the breast tenderness, uterine cramps, we talk about hypertension, headaches. These come from the estrogen component, so having too much. If there's not enough estrogen, there will be breakthrough bleeding in the early or the middle point of the cycle. So patients come in complaining that on week 2, they're bleeding again, maybe we need to increase the amount of estrogen to provide that cycle control that the estrogen component is kind of there for in addition to preventing ovulation. For progestin, this is where those anti-androgenic effects or androgenic effects come in. As I mentioned previously, weight gain, oily skin, acne, extra hair, which is the hirsutism, fatigue, and changes in mood can come from having too much of the progesterone. Having not enough would be breakthrough bleeding, but in the later part of the cycle. And so I think this is kind of a big role that we can always play with education and with making recommendations to your providers, is taking a look and really assessing patients for these symptoms to optimize, the efficacy but also safety and convenience of these medications for these patients. Where it comes to kind of monitoring parameters, our efficacy is going to be the pregnancy, but really the safety portion is looking at those adverse effects, continuing counseling on sexually transmitted infections, making sure patients are still doing their annual checkups, and then also monitoring those cardiovascular risk disease states such as hypertension, BMI for the weight, lipid panels, sugar, and when it comes to diabetes, to ensure that no additional risks are working together to potentially harm the patient. Again, this kind of just explains what we talked about. I like graphs, and so I always kind of have something to refer back to, and I think this will be helpful when studying, making sure you understand the why between, which, a 35-year-old healthy non-smoker compared to a 35-year-old smoker. The difference there is the increased risk of cardiovascular disease, and that combination with estrogen is where you would see these potentials for harmful effects. This also is just kind of a helpful acronym. I think I remember learning it in RX Exprep, which you guys will become very familiar with in a couple of years, to just help to remember the side effects that can present from those potential very harmful side effects from the hormonal contraception. Again, wouldn't make you fill in the blank anything, but just kind of helpful to study. I'm trying to hurry up because I know we're going to have a break in 4 minutes. When it comes to over-counter or kind of complementary additional contraception options, the diaphragm or cervical cap, this is something that I feel like I haven't seen used frequently. These are fitted by a healthcare provider, so a woman would have to go into a provider to get fitted for something like this. And it has to be readjusted for significant weight loss after having a baby. Pretty decently inconvenient for patients. They are used in combination with a spermicidal gel to increase efficacy. And you can see it's kind of very cumbersome to kind of time insertion. That must be done at least 6 hours prior to intercourse and then left in for 6 hours after. But no longer than 24 hours, otherwise you kind of increase the risk of toxic shock syndrome or any kind of infections from kind of foreign body being in place for too long. Other barrier methods, male condoms cover the genitalia, same with female condoms. There are some data showing that female condoms are a little more protective against sexually transmitted infections because of the amount of coverage of the actual anatomy of the body. But otherwise, as we remember from the big graph, generally about the same. Spermicide is, I did not write this on here, but it's probably important to know, non-oxynol 9. And I can type it up and show you all. Is the active ingredient in spermicide in the United States. There's only one, so that's the reason I think it'd probably be important to know. But you know, the spermicide comes in a variety of forms, in a gel, cream, it can be in suppository form, in foams, all sorts of things, but generally not as effective as some of the other options we've talked about. And then for the sponge, this is a kind of similar to the cervical cap, but it is not required to be fitted. It's just a temporary insertional device that is usually covered in a spermicide as well. Also kind of have these 6 hours before, 6 hours after, but don't leave it in too long requirements, which makes it a little less desirable. We can, actually let's do this and then we're pretty much done and we'll take a break. So lastly, in the contraceptive realm, we kind of talked about pills, patches, vaginal rings, IUDs, all the things, but emergency contraceptive is sometimes necessary, whether patients are on hormonal contraceptives, using their methods, sometimes things happen. You realize you missed 3 days of your pills, you're both too late, or the condom broke. There's always different scenarios. So first line options, Plan B, One Step, and most people have also probably seen this in your Walgreens, H-E-B, Walmart, on the TV. This is levonorgestrel. It's a 1.5 milligram dose. It's just one time. It's available over the counter. It is indicated for unprotected intercourse up to 3 days after, but there is some data showing that it is effective up to 5 days, just less effective in that 3 to 5 range. There's a bunch of different generics over the counter, Next Choice, One Step, there's a whole bunch of different ones. But they generally are all that levonorgestrel, 1.5 milligrams taken once, within a 3-day time frame, sum of efficacy between 3 and 5. Generally all over the counter, prescriptions are required for any females under the age of 17, but otherwise readily available for those to get over the counter. The Ella, which is our prescription option, is indicated for up to 5 days, and so if a patient came in, on day 4, didn't feel comfortable kind of with the risk of being after 3 days for the Plan B, Ella is an option. Again, it's just a one-time dose. This is a 30 milligram dose, but it has to be prescribed by a provider in order to, be used. It is important to counsel patients, let them know that use of any emergency contraception can affect the regular menstrual cycle, either, having their period early or later is something that can occur. And if there is no period after 3 weeks from the use of these medications, then a pregnancy test needs to be taken to ensure that pregnancy is or is not occurring. Medication safety, this is just side effects, kind of talk about everything. But typically important to know in bold, of course, is that these side effects can get better with time. So allowing at least 3 cycles of a new or different hormonal contraceptive go through to see if there is improvement before adjusting right away. All right, that was a lot. I talked a lot longer than I thought I was going to. You guys can take a break. If you have any questions, come up here and see me. We'll start back at 11:02. Go with that. Hydrochlorothiazide and a prenatal vitamin, just once a day. Other than just social use of ethanol or alcohol, patient reports no tobacco or illicit drug use. She does state that she is concerned about losing her pregnancy weight. And her blood pressure today is 178 over 96. It was 188 over 102 2 weeks ago. So what is the most appropriate hormonal contraceptive options for this patient? Is there anything that anyone would like to shout out that maybe we should be considering? It doesn't have to be an exact option, but something that stands out in this scenario that we should consider when thinking about what to recommend for her. Blood pressure, agreed. And so blood pressure, 178 over 96, 180 over 102, that brings a concern for which component of a combined oral contraceptive agent, the estrogen or progesterone? Perfect. She's also on, she's on the Cinepril, she's on hydrochlorothiazide, and her blood pressure is not doing great. So we don't, we have some caution there. Anything else that stands out in her kind of scenario? She's not breastfeeding, but she is 6 weeks postpartum. And so we kind of discussed how that's about the mark where you can consider reinitiating any type of hormonal contraceptive, but kind of still, waiting at least 6 weeks because of the estrogen risk for venous, for clots. So because she's not breastfeeding and is at that mark where we can start considering estrogen-containing contraceptives, that's okay. Anything else that sticks out to you guys? Or what? Her weight. Yes, I thought I put a BMI, but I did not. But she's concerned about weight, and so we know that one of our 2, estrogen or progesterone, is more likely to cause weight gain. Do y'all remember which one that is, estrogen or progesterone? It's those androgenic effects, if that's helpful. Progesterone, I heard it there. Yes. And then the last thing that I kind of noticed is her age as well. She is 39, and 35 is where we start really considering the risk versus benefits when it comes to cardiovascular disease, risk for clots, risk for those estrogen-based side effects. So here I didn't even give you any percents of, or formulation and concentrations of ethanol, estradiol in the progestins. So for Depo-Provera, this is medroxyprogesterone. I was going to ask what it is. Obviously, it's progesterone. Do we have any concerns on this one off the top of your head? The weight gain, okay. So Xulane has both an estrogen and a progestin, so does Yaz. And then Mitranor is just progesterone alone, but it is one of those synthetic versions that is a little bit more friendly than the progesterone, which is medroxyprogesterone. And so I think from this part, you can cross out B and C pretty quickly. We don't want to do estradiol in this woman because of her blood pressure. We've got it down to our 2 different progesterones. Depo-Provera, I got this from a casebook. You guys don't have to know this one, but for FYI, Depo-Provera is one of the more weight gain, associated with more weight gain than other options. So that is where you would cross out A. But you can also kind of get that from looking at that breakdown of the different progestins. Our norepinephrine is on the more anti-androgenic, so less weight gain, less acne, less hair growth in comparison to medroxyprogesterone. So the correct answer here is answer choice D. For our second case, we have a 21-year-old woman who has been taking contraceptives X for the past 8 months. She called today because she has had some breakthrough bleeding for 2 days, and then her period begins 4 to 5 days later. She states it is bothersome to have so much bleeding in the past 2 cycles, and her past medical history does include dysmenorrhea. And so she's on product X. We've got A, B, C, D to consider. If we are having breakthrough bleeding 2 days, breakthrough bleeding for 2 days, and then her period occurs 4 to 5 days later. What type of, is this early, mid-cycle, late cycle breakthrough bleeding? You have to take it in. So what day is the first day of the female menstrual cycle? First day of menses. So if it's happening about 2 days, and then her menses is happening, so it's actually occurring at the late part of the cycle, because the first day is when menses starts, and this is happening right before it, so the very end of her actual female menstrual cycle. So kind of making sure that you know those terminologies and kind of how the actual cycle works will be helpful. And so since she's having late cycle breakthrough bleeding, which component, our estrogen or our progestin, or I guess our androgen, could be the contributing factor, and is it a deficiency or an excess? Correct. I had to think of my chart in my head. So yes. So because it is the estrogen would be a mid or earlier mid deficiency. Progesterone is the late. And so basically from our ABCD options, we're going to pick the one that has more progestin than her current product. And so the only answer choice that has that is product A. And so that would be the correct choice here. And then lastly, for case number 3, a 17-year-old patient is crying in the waiting room saying she needs help. The front desk asks you to talk to her. She states that a condom broke during intercourse 4 days ago, and that she wants to use emergency contraceptives. She states that the pharmacy down the road refused to provide her Plan B1 step, and told her that she should not have sex until she's older. Her medical history includes pelvic inflammatory disease, which is treated and is resolved, and she does report several sexual partners. What is the best choice of action? So from this, we cleared up the 17-year-old thing. But we're going to go ahead and say that the pharmacy down the road was wrong in their judgment of her sexual endeavors. But we have 4-day intercourse, so what are our concerns there? Correct. So Plan B, there's a potential decrease in efficacy after 3 days, but it is okay. There's some efficacy up to 5 days. The answer choices here are refer her to a different clinic to get the Plan B, levonorgestrel 1.5, but do a Q12-hour for 2 doses instead. Recommend that her physician insert an IUD, have her physician prescribe ulipristal 30 milligrams times 1, or refuse emergency contraceptive because it's been too long since her unprotected intercourse. Anyone feel strongly on any of the answer choices? Correct. So ulipristal is going to be the best option here. Can be given up to 5 days after unprotected sex. And if she was in a clinic, maybe the doctor has some samples, or could write the prescription, go to the pharmacy, pick it up within a day to take it. The contraceptive is not correct. We know that it can go up to 5 days. The IUD is incorrect. It is, I guess, FYI. The copper IUD can be inserted emergently as an emergency contraceptive option. You guys don't need to know that, but basically, levonorgestrel would not do anything at that point in time. And then the reason it's wrong for the over-the-counter, it's not the best choice because of the 3 to 5 day kind of concern, but also that dosing is incorrect. It is supposed to just be 1.5 milligrams times 1. There is no recommendations for additional or higher doses or longer doses at this time. Any questions on any of the patient cases?
So which one is the answer for this one?
That one was answer choice C like cat. Alright, my goal is to get y'all out of here early. We're gonna make it happen. This is going to be fast. So for infertility, we are going to go over the ovulatory disorders associated with infertility, identifying treatment regimens and monitoring parameters, really more so side effects, and then recognizing the side effects that are associated with the treatment regimens. So, for background, we've already talked about this a little bit. Women have about an 85% chance of getting pregnant over 1 year if no birth control is used. Approximately 20% of women will have their baby after the age of 35, and that's where there's increased risks for cardiovascular disease, as we mentioned in contraceptive talk, but also increased risk for genetic diseases, multiple births. After 35, unfortunately, women, it's considered a geriatric pregnancy at 35, which I think is rude, but I don't know about everyone else here, but pharmacy school took a lot of my life, and I'll be geriatric soon, apparently. But the probability of having a baby decreases every year after 30, and even faster after 40. And miscarriages are common, just generally, but are more common as age increases. And so you can see where the infertility concerns can come up as females age. And technically the definition of infertility is the inability to conceive after 1 year of unprotected sex, so 1 year. There are some references that considered, because of the risk and the difficulty getting pregnant, the potential risk of difficulty getting pregnant after 35, that starting this process after only 6 months of unprotected sex for the geriatric females, in order to kind of preserve more of the body's ability to do so. But generally, infertility definition in red after 1 year of unprotected sex. Risk factors that can contribute into infertility risks: age older than 35, tobacco, alcohol use, caffeine use, vitamin D deficiency, excessive exercise, stress levels, and then a BMI outside of a normal range. Sexual history, basically meaning that certain sexually transmitted infections previously in life or currently can impact the ability to get pregnant. And then other medical histories such as eating disorders, any disease of the general anatomy, thyroid disorders affecting general hormone control throughout the body, and diabetes as well. For the types of infertility, there are 3 main types: ovulatory, cervical, and pelvic. Cervical and pelvic are more of anatomical abnormalities or differences in like mucus or damage or something along those lines. They're typically not treated with medications, so we won't really focus with that here. The ovulatory type is the one where medications are used more frequently. So there are 3 different types defined by the World Health Organization based off of the types of hormones, hormone levels in a patient who is concerned for infertility. There's also a 4th type of ovulatory, which is hyperprolactinemia, because hyperprolactinemia basically works kind of in that same negative feedback pathway that the TSH, LH, estrogen, progesterone, because it is stimulated by the gonadotropin releasing hormone in the hypothalamus. And so if that negative feedback due to high prolactin is telling the body to quit secreting that gonadotropin GnRH releasing hormone, then FSH, LH, and then in the long run, estrogen, progesterone will also be affected. And so treating the hyperprolactinemia could reverse infertility. When it comes to the group 1, 2, and 3, hypogonadotropic, hypogonadal anovulation, which are terrible words. Basically, it just means low FSH. The gonadotropic, when it comes to eugonadotropic, hyper, the first part of each of those groups is going to be in relation to FSH concentrations. So hypo being low, U being normal, and hyper elevated FSH. When it comes to the hypogonadal, whenever we're mentioning that in the group 1, that just means that there's low estrogen as well. And so I noted on here group 2 is typically where you see your PCOS, or someone referred to it as PCOS the other day, and I was like, what is that? So I know they already talked with you guys about that last week. They fall into the group 2. And typically advanced age or premature ovarian failure to where there's not enough hormones is typically in group 3. So the goal for infertility treatment is, of course, to achieve pregnancy with minimal risk and side effects. It is, like I said, the ovulatory group is where drug therapy is focused, but there are different procedures, surgeries that are used very frequently. I'm sure everyone's heard of in vitro or intrauterine insemination in order to get pregnant, depending on the reason for the female's inability to get pregnant. This is a very, I feel like, touchy subject. It's very distressing to most people, whether it's just the female alone, the whole family, the husband, or whoever else can be going through, the partner, I guess. It also is very costly when we get into the drug therapies as well as some of these surgeries, and very time consuming. So this is a very, sore subject for a lot of people, so taking that into consideration when we do have to have those conversations with patients about these medications. So, non-pharmacology treatments or recommendations that can be made for all of the patients that are concerned about infertility, whether it's been a full year or not, but ensuring that basically living a healthy lifestyle can significantly impact the ability to get pregnant and stay pregnant. So avoiding different medications that can interfere with infertility, or food or medication, so nicotine, alcohol, illicit drugs, any of the, now that you guys have probably all been in the outpatient pharmacy, the hazardous drugs, a lot of them are due to teratogenic effects. So avoiding handling those, if you're a technician or pharmacist, being as careful as possible to not increase your exposure to medications that would impact fertility. Achieving a BMI within the normal range, less than 27, but also not too low, because that can also not allow for a successful pregnancy. Eating well-balanced diet, managing stress, taking your vitamins, testing for ovulation, and then timing intercourse. I assume that's you guys have gone over this, but we talked about how ovulation for a woman in the contraceptive portion is, a 24 to 36 hour window. When an egg can be fertilized, sperm is typically viable for up to 5 days, and so really ensuring that the timing was correct to increase likelihood of pregnancy. Water-based lubricants, I thought was kind of unique. There's multiple studies showing that the water-based lubricants kind of decrease sperm motility, and then therefore can influence ability to get pregnant. So avoiding those is a consideration if it were to come up in a conversation with a patient in this disease state. This is kind of just the reminder, because the drugs that come with this is from earlier, the PowerPoint, I know you guys don't have the slide, but just to make sure, because when it comes to the different medications, they're basically separated into what hormone they're affecting. And so really knowing the different hormones and what their role in the normal menstrual cycle, the normal pregnancy conception is important to be able to kind of recognize their role in a infertility regimen. Because typically it is not just going to be, it starts with one agent, but if one agent has failed, then it becomes a multiple agent regimen. And so, looking just kind of back at the graph, we remember that FSH at the very beginning helps with egg maturation, and having that oocyte mature and be ready to be fertilized if intended. The LH is the final egg maturation, and this is that LH surge is what causes ovulation. Then our progesterone is what typically induces your menses or period, and it also is helpful with supporting the thickening of the endometrium to support pregnancy. So if you remember progesterone, this is the hormone that's going to kind of ramp up to get ready for pregnancy, and that's why you can see at the very end of the cycle, kind of around when implementation will be happening, it's very high, preparing everything for the potential pregnancy. And then estrogen, it works more so at the beginning, but if the levels are off in any part of these, 4 major components, then it will throw off the cycle completely and could potentially cause or impact fertility chances. So this is just kind of the breakdown of the different medications that are used in infertility treatment. And so we have selective estrogen receptor modulators, or SERMs, which is kind of the focus for today. Clomiphene, which they may have gone over a little bit in the PCOS, module. Here, there is also the aromatase inhibitors, which are actually off-label use, but they have been shown to increase the GnRH and other gonadotropins, which is everything in the pink red section, which could then basically induce ovulation. The overall arching theme here is trying to ensure that ovulation occurs, and then can provide other medications to support the continuation of pregnancy or to prevent miscarriages later on. But here, this is your ovulation-inducing agents, and it's all based off of the hormones and for which that specific female may or may not be lacking, needing less of, needing more of, etc. So clomiphene, or Clomid is the brand name, our selective estrogen receptor modulator. It acts as estrogen, so basically sits on the receptor and causes that LH-FSH surge right around day 14 to cause ovulation. This is indicated for patients where you've kind of ruled out the other causes, such as like pituitary or ovarian response, any type of anatomical abnormality. You need to make sure that the hyperprolactinemia is not playing in here, and if so, treating it first. It comes as a 50 milligram tablet. It's dosed for 5 days, and it starts on day 5. So lots of times. 50 milligram tablet, start on day 5, 4 or 5 days. That's important. With almost all of the infertility drugs, multiple births is a risk that comes with them, and I think most of us have probably met someone who has gone through infertility and has ended up with 2, 3, 4 kids at a time. Kind of place in therapy for the aromatase inhibitors, though, like I said, off-label use, but those agents do not increase the risk of multiple births, so that if that's a concern, that's where those can play a role. Another key side effect for clomiphene is hot flashes, which makes sense because we are acting as estrogen. For our gonadotropins, which was this pink section of the graph, please don't memorize these names. This is, I feel like, a very specialized disease state. I have personally, since I worked as a technician, I've been running pharmacies since almost 10 years. I've never seen any of these. Outpatient, inpatient, I've seen some of them, but not necessarily for during fertility. So I don't think it's necessary for you guys to have these 100% memorized, but knowing the role of the different gonadotropins and how those would affect the cycle, I think is most important. And then you can always figure out what the names of those medications are. So you can see the different hormones that we've talked about previously. The only ones in here that I don't think we've talked about specifically is the human chorionic gonadotropin and human menopause gonadotropin. Those are both similar to LH, or luteinizing hormone, and have the same effects when considering use. So, these are mimicking our endogenous gonadotropins, like I said, that kind of graph of really understanding FSH, LH, estrogen, progesterone in order to trigger ovulation. These are more expensive, these are injectables, so typically saved for poor response to clomiphene alone in order to promote ovulation. Again, side effect is multiple births, and because it's kind of working in the long run to increase estrogen, you can see the same amount of, same types of side effects. Other fertility agents, progesterone is more so used after the fact. Like we have mentioned a couple of times, the gest part of it is really it's important because it supports the pregnancy overall. So hormone replacement in order to develop an embryo. So this is typically administered after the egg has been taken out or been basically ovulated, and this is to promote adequate uterine lining, as well as make the environment for which a pregnancy needs to be sustained, not only occur but sustained, most optimal. So this is also considered for use in patients with frequent miscarriages, who may not have problems with actual ovulation, but have problems with maintaining a pregnancy because the environment in the uterus is not optimal. Progesterone would be your option of choice there. Other options that you guys may see or have questions about, metformin has been used in conjunction with clomiphene, specifically in PCOS, which I know you guys talked about. Bromocriptine is an option for treatment of hypergalactonemia. More likely just important to know that hypergalactonemia works in that same pathway, and that's where the necessity to treat it first comes from. Sildenafil, guaifenesin, and aspirin are things that I had never heard of, and when I was reading I thought were very interesting. And so off-label uses for all of them. Sildenafil aids in increasing uterine lining thickness. I have actually had patients tell me in like a retail pharmacy setting about guaifenesin, that they would take that when they're trying to get pregnant, like within a month they're pregnant, and so be careful when you're taking your cough and cold medications if you are not trying to get pregnant. But the theorized mechanism here is to help thin cervical mucus to aid in conception, basically allowing the sperm to get to the egg better, which makes sense for it being an anti-mucus agent. And then aspirin is used before fertility procedures for uterine blood flow, typically avoided during pregnancy and in early childhood because of Graves' syndrome. So, basically, like I think I've hit it on the head a couple of times, really knowing the hormones and what their role is will help you to best understand their role in infertility treatment. This is just an example, again, FYI, of what an infertility treatment can look like and how intense and involved it can be, and why this is such a difficult thing for people to go through. Lots of drugs, lots of injections, lots of timing, and waiting for hopefully positive pregnancy tests, which may not always occur. But this kind of shows you, if you compare this to the actual graph with the different hormones, you can see where it is similar, and it's just basically trying to mimic a normal response to the body in order to get pregnant and sustain a pregnancy. Like I said, that was going to be fast. So I have the question, I have the cases on this one. For infertility, it is more like content-based and not case-based. Because I think the contraception portion is going to be what you guys see most often, and will be most helpful to know, for this part of your didactic training. Do you guys have any questions for me over infertility specifically? And if not, go ahead. If not over infertility, over anything at all? Alrighty, I think I have 6 exam questions from this 2 hours, so. Do with that, but
Wow.
and then I will be back tomorrow to talk to you guys about male health.
Are you gonna be with the other doctor, or is it just gonna be?
It'll be me and Hiba or Dr. Almazri, as you guys met last week. I'll be talking to you guys about erectile dysfunction and male infertility or hypogonadism. She'll talk with you guys about benign prostate hyperplasia. Yes.
So, for this presentation,
Mhm.
do you have like any areas of concentration for your 6 lecture?
I think,
What was it?
just in case you missed it, really knowing the roles of the hormones and either preventing pregnancy or promoting pregnancy is going to be the best way to study for the exam, knowing this, on the contraception side, knowing the side effects of estrogen versus progesterone, when it's in excess or deficiency. Again, you don't need to know exact, like formulations. I'll give you all that information if it's needed. Don't worry about IUDs or Depo-Provera or implants. Try not to get too much away, but I think that's what I have marked on here to do, you guys. I'm just bringing these back up to show you. So like here, you will never need to know the concentrations of Zoomlights. Yes, please don't memorize that. I couldn't tell you that if my life depended on it. But this is kind of more of how I want you to think about things is like what risk factors, where that risk factor is coming from, and what we should do to kind of mitigate that. Look at this. Yeah, and if, like you see how I put levonorgestrel 1.5 milligrams. If it's not important, it'll be in kind of parentheses like that. Does that help at all? A little bit, hopefully maybe?
Yeah,
Okay.
you can keep going.
That sounds like 4 questions.
That's, yeah, I think I remember. I wrote in the midst of like 3 hours of sleep one night, like 2 a.m. So, yeah. If y'all have any questions, my email is on there. I will be here for the next 15-25 minutes if you have any questions and don't want to speak out loud. Also, like I said, please feel free to contact me if y'all have any questions on like residency, after year, life after staying in a classroom all day. I like talking about that stuff more than I like talking about birth control.
I mean, how is your residency running? How was the first one?
First one, for me personally, I had no idea, and y'all can go, y'all have to listen to the chat if you want to. For me, residency, I didn't know what I wanted to do. Like I went into people, you're like, I don't know. I applied for everything. So it really helped me decide what I like to do. Because I was open to ambulatory care, infectious diseases I liked, and pediatrics, which are all very all over the place. Infectious disease is fun, but it is intense.